The broadcast is now starting. All attendees are in listen-only mode.
Good morning, good afternoon, everybody, and welcome for this new issue of Bonecast dedicated to an important topic, sarcopenia. And welcome to our speaker today, Professor Gustavo Duque. I'm Philippe Albour, IOF Chief Executive Officer, and I'm really delighted to introduce this webinar this morning. A webinar jointly organized and supported by our sister society, ESCEO. So I take this opportunity to warmly thank Professor Jean-Yves Regenster, President of ESCEO, who is with us today. Professor Regenster is President of ESCEO, Chair of the Committee of the National Societies and co-founder of IOF. And Professor Regenster made this webinar possible as organized with ESCEO. Indeed, the IOF and ESCEO have a long-term partnership based on our complementary skills. As you may know, IOF is mostly specialized on osteoporosis, fragility fractures, whereas ESCEO has other skills and interests in osteoarthritis and sarcopenia. And time to time, we are very, very pleased to organize a joint event like this one. Our tight collaboration is also illustrated by our joint global congress, the WCO. And today, if you are attending this webinar dedicated to sarcopenia, I invite you to join us end of August, 20th up to 23rd, to attend the WCO virtually due to the COVID-19 situation. But the Congress will take place and will include, will make a large part to osteosarcopenia and other important bone disorders. Welcome to this webinar. A few words regarding Professor Gustavo Duque. Professor Duque is a very well-known expert in sarcopenia, has a huge background, very difficult to sum up in a couple of minutes. But to let you know, Professor Duque has major research interest in a lot of bone disorders, including bone loss, osteoporosis, sarcopenia, frailty, falls. Currently chair of medicine and director of the Australian Institute of Musculoskeletal Science at the University of Melbourne and Western Health. Professor Duque is also director of the fracture care and prevention program at Western Health in Melbourne. And part of this program, Professor Duque is extremely committed in falls prevention and fractures, setting up a falls and fracture clinic at Sunshine Hospital, and a very interesting service in which patients are assessed for falls and fractures risk in a comprehensive manner. Thank you very much for your commitment, Professor Duque. It's a great honor to welcome you for this Bonecast. And now the floor is yours, if I may, virtually at least.
Good morning, everybody. Good afternoon. I'm Dominique Pierrot, the science manager at IOF. Before giving the mic to Professor Duque, I just would like to inform you that attendees are automatically muted, and I would like to encourage you to ask questions during the webinar by typing your question in the question box of the GoToWebinar control panel. And I will be very happy to voice the questions to the speaker towards the end of this webinar. This being said, I'm happy to welcome Professor Duque, and please, Professor, we are listening to your presentation.
Thank you very much, Philippe and Dominique, for the introduction. Good morning, good afternoon. It's a real pleasure to be here. I would like to first start by wishing you to stay safe and healthy during this terrible pandemic. And I would like also to thank IOF and ESCEO for inviting me to talk about osteosarcopenia today. So let's start a little bit of a history and the context of why we are talking about this topic. As you probably know, during many years, the concepts of osteoporosis, osteopenia, and fractures were relatively fragmented from or separate from the concept of sarcopenia and falls. So the identification, diagnosis, treatment osteoporosis and prevention of fractures usually was under the care of specific areas of medicine, and the identification of sarcopenia and folds were under other teams. And as I said, it was quite a fragmented model. But recently, it has been understood and probably realized that these two events are connected, and that a significant proportion of fractures happen after a fall, and therefore there must be some kind of connection, not only between the mechanisms and the consequences, but also between the tissues that determine mobility and resistance to trauma and fractures. And those tissues represent 55% of our body mass. So there must be something that determines that there is a connection, a physiological connection, and there is also a what we know an age-related loss in both tissues. So you can see here, for instance, this is data from the G-Long osteoporosis study by Judy Pascoe, how both bone and muscle decline with aging. They probably don't decline in a parallel way. They don't decline in a very nice symmetric way, but you can tell that both of them go down. And since both of them go down, there must be something happening in both of them that predisposes them to a decline with aging. But this, if we consider a physiological change, what happens when this change, this decline in bone and muscle mass is pathological? And this is where the concept of osteosarcopenia came out. Since probably 2009, some people have been talking about sarco-osteopenia, sarco-osteoporosis, but most recently, several groups, including ours, have been proposing that we should refer to it as osteosarcopenia. And I will tell you very quickly, and again, this is a more historical context before we get more into in-depth into the field, is that suddenly when you look at the risk factors for osteoporosis and sarcopenia, we can identify major similarities. And usually I ask my audiences, unfortunately here it's online, but when we have a face-to-face audience, I always ask, tell me one risk factor that is not shared between osteoporosis and sarcopenia. We also know that there is a clear connection between the muscle and bone, and I will just go into this very soon. And therefore, if we think about similar risk factors, connected tissues, two syndromes that are associated with similar outcomes, then there is clearly a syndrome here that I will try to demonstrate today in terms of the biological, to the clinical, to the therapeutic basis. So the concept of osteosarcopenia has been growing. You can see here that since the first time it was mentioned about 2009, 2010, the number of papers in the literature is growing. And this has demonstrated the increasing interest in this field, or specifically in this condition, because if we compare it to 20 years ago when sarcopenia just started, and I didn't want to draw that parallel today because I just want to move on to more biological and clinical aspects. But I can tell you that 20 years ago, if you look at the numbers of papers in sarcopenia, we were around this same level that we observed in the last 10 years in osteosarcopenia. But let's say that any condition in medicine has to have a biological basis. And that's why I think that it's important today to consider the pathophysiology or the shared pathophysiology between osteoporosis and sarcopenia that may explain the pathogenesis and appearance of osteosarcopenia. So for those of you who are not familiar with the concept of geroscience, geroscience has been also another concept that has been developed from the NIA relatively recently, where several mechanisms are triggered by the aging process, but at the same time affect specific organs and systems. Therefore, we have proposed, and this is just a summary that we recently presented, and how all these different factors that are regulated by aging are affected during the pathogenesis of osteosarcopenia. So I will try to highlight the ones that we think are the most important and most relevant, and the ones that are where we really find a connection between aging and the deterioration of both muscle and bone. I will refer today a little bit about stem cells and regeneration, a little bit about metabolism, a little bit about epigenetics and genetics, and a little bit of adaptation to stress. Just to highlight the point that in the pathophysiology of osteosarcopenia, we are talking about not only gerosines, but also a common and shared mechanisms. So when we are talking about this topic, we should consider changes both in bone and muscle. And I have summarized all these changes in three different aspects or different approaches. One is those common mechanisms that happen at the same time in muscle and bone that we observe with normal aging, but that are more dramatic and more pathologically developed in osteosarcopenic patients. The second one, which is very interesting, is how defective muscle leads to defective bone. And we will talk about this communication and very intrinsic, complex crosstalk between muscle and bone. But very interestingly, and recent evidence has demonstrated that the opposite direction is also relevant and important to explain not only the bone and muscle physiology, but also the bone and muscle pathology, and in this case, osteosarcopenia. Let's start with the common mechanisms, just reminding you about that gerosines story. So probably the one that is the most interesting is particular to our team, and the ones that we have generated, we and others have generated a lot of evidence in terms of this connection, is logically alterations in mesenchymal stem cells. Mesenchymal stem cells are the precursors, shared precursors to muscle cells and osteoblasts. At the same time, these cells are the precursors of adipocytes, and that's where the fat connection starts. Very naturally, when we propose a hypothesis to explain the pathophysiology of something that happens in bone cells, we also connect if there is some kind of disturbance or abnormality on the differentiation or function of these mesenchymal stem cells, well, it should also affect the other cells that are originated from the precursors. And that's our overarching hypothesis, is if we have alterations in muscle, we have alterations in bone that happen almost synchronically, then there must be something going on in the precursors. And the most important hallmark and shared hallmark between osteoporosis and sarcopenia is definitely fat infiltration of these tissues. If you look at that sarcopenic muscle, and I'm pretty sure all of you who are familiar with sarcopenia have seen this many, many times, you can see that fat it not only surrounds the muscle, which is a common finding, but here is much more interesting, because here what we see is an infiltration, an active infiltration of fat within the muscle. And it's not only between the fibers, as we can see here, but also inside the fibers. These adipocytes that infiltrate, or this fat that infiltrates the muscle. And please keep this image in your mind, because you will see the similarities between a muscle infiltrated by fat and a bone, an osteoporotic bone that is infiltrated by fat as well. Here you can see a young bone, healthy, with a healthy bone marrow, with healthy osteocytes. And here what you see is an osteoporotic bone, where we see unhealthy structure, unhealthy osteocytes, but very dramatically significant levels of fat infiltration. And more recently, it has been demonstrated that the fat infiltration doesn't only go around the bone marrow, infiltrating the bone marrow, but also infiltrates the osteocyte lacunae with a significant effect that is very similar between what we observe in the bone and osteoporotic bone and the fat that infiltrates that bone and muscle. In the osteoporotic bone and that fat infiltration that happens in that bone, and this is important because we know that some areas of the bone are infiltrated by good fat and some areas are infiltrated by the bad fat. But unfortunately for us, with aging and in osteoporosis, the areas that are infiltrated with the bad fats are the areas that break easily, such as proximal femur. And that, what we call bad fat, is the one that produces some factors, adipokines and fatty acids, that decrease bone formation, affect all the function and, of the osteoblast, increase apoptosis and the osteoblasts and osteocytes, and increase osteoclastogenesis. When we look at, so in overall, when we expose bone and bone cells to fat and to fat products, and this type particular of fat that characterizes bone marrow, these cells are predisposed to premature cell death and dysfunction, and overall significant catabolic stress and catabolic situation. In the muscle, we observe a similar situation. When muscle is infiltrated by fat, we observe very similar response. I know that muscle and bone have different cells overall, but the way the cells are affected, the way the cells develop apoptosis, the way the cells induce a catabolic state is very similar by what we observe in muscle and bone. So our initial concept is that when these stem cells lose the capacity, or affect the capacity with aging and osteoporosis and sarcopenia to really differentiate into muscle and bone, they start differentiating into fat. That fat becomes toxic, and that toxicity induces all these catabolic stages that affect bone and muscle mass and function. But what can explain this? Why these cells, what would be the mechanism? Why these stem cells end up producing more fat, less bone cells and less muscle cells, or at least affecting their function? Well, there are several theories, and several of our colleagues have proposed different theories. Our theory started here, and this is an interesting case that we published a while ago of a Hutchinson-Gilford progeria syndrome. For those of you who are not familiar with progeria, this is accelerated aging. And interestingly, these type of patients, which are not, there are not too many in the world, are probably 250 reported. These patients have severe osteoporosis, and at the same time, they have some significant muscle alterations. In 2003, the mutation on these patients was reported, and it was reported that they produced an aberrant type of this protein, which is lamin AC. And I say this is history because this was what triggered our interest on this protein. Because what happened with this protein is, first, as I mentioned, mutations in this protein induce accelerated aging, coming back to Geroscine's story. And you see where the lamin is, which is in the inner nuclear envelope. Lamin has the potential to interact with many different transcription factors that regulate replication and cell differentiation. Amongst them, the differentiation of mesenchymal stem cells. And why I say that is because when we look at mice who don't have or don't produce lamin AC appropriately, they are significantly osteoporotic, and the bone marrow becomes significant, especially the male mice become significantly infiltrated by fat. When we take ex vivo cultures of those mice, we can see that those cells, even in osteogenic conditions, they tend to produce fat and differentiate into adipocytes, and they definitely express higher level of adipogenic factors. So one of the working hypotheses we have regarding lamin AC is that if a stem cell has normal levels of lamin AC, then the interactions with the differentiation factors is normal. The cell can differentiate into osteoblast, if the cell loses laminin AC, which is something that we observe with aging, then they predispose to produce fat. And therefore, our next step was demonstrating that this laminin AC, or lack of laminin AC, could show a phenotype that is compatible with osteosarcopenia, and we reported that our hypothesis was that in those animals, we're going to observe the typical features, so bone loss and muscle loss, which we observed, but more interestingly, we were going to observe that fat infiltration inside the fiber and between the fibers that we normally observe in sarcopenia. When we did that with histology and also through micro-CT, we could identify lots of fat infiltration, not only in the bone marrow, but also inside the muscle. And that was our support to propose the laminin AC knockout, a model of osteosarcopenia. Since then, several groups have confirmed these findings, and other groups have proposed other animals that are also affected or have showed changes in muscle and bone mass. However, and I would like to highlight this, is that this model has a particularity, is that this is also a model of progeria. So we have the three components. We have the aging component, we have the osteosarcopenic features, and we also have the fat infiltration component in this model. But for those of us who are also interested on hormones, well, definitely hormones are regulators of bone and muscle. And when you look at the different hormones, and this is just a summary of a few of them, most of those hormones have an effect on muscle and bone. So rarely these hormones have an exclusive effect on one of these tissues. Probably the effects are a little bit different. Probably the receptors are a much lower number in one of the other, but at the end, both muscle and bone, when exposed to these hormones, develop some level of response. And when we look, for instance, at vitamin D, we know that vitamin D is one of the well-known factors to induce osteoblast differentiation and to induce bone formation. But we also know that there are receptors for vitamin D in the muscle, and that there is a biological response in muscle cells exposed to vitamin D that induces the generation and release of some factors that go from the muscle and to the osteoblast, which I'm going to talk about soon. Same story with the IGF-1. We know the IGF-1 regulates different pathways, some of them actually very similar between muscle and bone, and that this connection cannot be just cut by blocking the capacity of the cells, well, the bone cells to respond to this. We know that there are multiple pathways that are shared between the muscle and bone. PTH is an interesting story because we know that PTH or an osteosarcopenic patient is a study from our team where we found that osteosarcopenic patients have the high level of PTH in their serum. And there is new, very interesting data coming from different groups, one of them from Rebecca Mason in Sydney, reporting that connection between PTH and muscle function. Now let's move on to the second part of the story, when we say that defective muscle leads to defective bone. Well, this is the paradigm. I remember when I did my musculoskeletal training during my med school and then doing my internal medicine training, they always told me about these mechanical forces between the muscle and bone and how the osteocytes respond to this. Well, I can tell you that, yes, this is still an important component of the story, but it's not the only one. Now we know that one muscle and a bone doesn't have to be connected mechanically in order to interact between each other. And to demonstrate that, there are many studies. This is just a good summary that was published in 2015 by Kawao from Japan. And basically, they summarize all these factors that are released from the muscle, go to the circulation, or just go through the tissues between one and the other, or for a different mechanism that we still don't understand. These factors are secreted by the muscle and reach the bone cells, having an effect on those cells. Some recent studies, and this is a summary from Mark Hambrick from the Augusta University, who has been working on this field for a while. And what they did is an identification of all these different factors that have this effect or can affect secreted by myotubes that affect the bone. Mark has also developed recent research in how these factors reach the bone, and this is a very interesting field. I know there was a recent webinar on extracellular vesicles, and that's probably where the field is moving towards to understand this crosstalk between the muscle and bone. So it's not necessarily that all these factors are released into the circulation by itself. Some of them are carried by extracellular vesicles, which are secreted from the muscle and reach the bone cells. The way they communicate, the way they carry those factors are still a very interesting area of research. Now, moving on, the other side of the story, that defective bone leads to defective muscle. And this area, there has been quite a controversial concept, but still we think that bone cells definitely, as muscle cells communicate with bone, definitely bone cells have some level of communication. They are at the end sharing the same precursor. They are at the end, coming from a similar cell. So all this machinery that they have, even if they have their own function, their own local role, they still have to communicate, considering that these two tissues are so much connected amongst themselves. Here, just to summarize, we have all the biological area, we have a mouse model, we have hormones, but what about genetics? And this is an interesting report published by Fernando Rivadeneira, David Karasik, Douglas Kiel, and their teams, and where they did this phenogram of all the different genes that show some results in terms of share bone and muscle phenotypes. They also identified some of these bone genes that have a molecular role on muscle. And this is an interesting, I really recommend for those of you with interest on genetics and how these connections have been identified. We participated in this one with the same group, with the same teams, and we reported the first bivariate G-Ways meta-analysis to demonstrate this pleiotropic effect on bone mineral density and lean mass. But why I'm mentioning this today, we published that in 2017, is because this gene, SREBF1, is closely, very closely connected and linked with lamin AC. So lamin AC is an important regulator of this factor, of the activity of this factor in stem cell differentiation. So this is something to keep in mind. And for those of you interested in this area, I encourage you to follow that track because it's an interesting story. Now, we have genetics, we have biology. What about the phenotype? What about the clinical phenotype? Who has osteosarcopenia? And here is where we find a little bit of challenges when the field is moving forward, because identifying a clinical phenotype is challenging, especially for one component. Probably the osteoporosis, osteopenia component of the syndrome is not that complicated because we know how to diagnose osteopenia and osteoporosis, but probably because the complicated concept of sarcopenia, not because it's a complicated concept by itself, but it's because of the difficulties that we experience in terms of finding an appropriate and standard definition worldwide. So when we are going to define about a phenotype, we try our best to identify who has osteoporosis and who has sarcopenia. We tried that in 2014 when there was only one definition of sarcopenia, or one major definition of sarcopenia. This is from our team in about 600 patients, where we all the patients, as you can tell, and we try to identify, well, if we identify a group of osteosarcopenic, what will be their characteristics? And basically what we found, and these are people attending to our falls and fractures clinic in Sydney at that time, we found definitely that they were older, that were mostly female, and that they showed the typical characteristics of osteoporosis and sarcopenia. So they had low bone mineral density, lower grip strength, gait velocity. So that was just a general understanding. Okay, we just confirmed, okay, what was expected? Well, if you are going to be osteosarcopenic, you're most likely going to be older, you are going to have both osteoporosis and sarcopenia, and you are much going to be most likely female, because female patients are at high risk of these two conditions. But the question is, and this is something that we are particularly interested in, is to answer the question, is osteosarcopenia a continuum? And this is just one of our proposed models. We are testing multiple models. One of our models is, okay, maybe, and this is something that we observed in that study and other further studies that we have performed, is maybe people first develop sarcopenia, start losing muscle, they start having some weakness, start suffering falls, and then they start developing osteopenia, while they're maybe also sarcopenic, some of them are osteoporotic, and once they reach the level of osteosarcopenia, then they move, they start experiencing functional impairment, falls and fractures, then they become frail with all the criteria, which, by the way, important component of frailty, clinical components of frailty are osteopenia, osteoporosis, and sarcopenia, and decreased mobility and high risk of falls. And then we have them reaching into disability, institutionalization, and death. So this is one of our overarching hypotheses, and it's something that we are testing, and we are testing in collaboration with multiple longitudinal cohorts around the world, is what happens first, and when do we reach the point of osteosarcopenia? Or maybe it's not a continuum, it's just a dynamic syndrome where a robust individual, and it doesn't necessarily be an old age, probably early on, or a robust individual with a set of comorbidities that affect bone and muscle mass, develop osteosarcopenia, start suffering falls and fractures, they experience social isolation, fear of falling, physical dependence, malnutrition, poor quality of life associated to these events, and then they become, again, a vicious cycle, or they just move into the criteria for frailty, disability, and institutionalization. So this is something that we don't know yet. We don't know where osteosarcopenia plays a role in the whole life of our individuals, whether this starts early, what starts first, and this is an interesting area of research for epidemiology. But what we know is that if osteosarcopenia is really a clinical syndrome, whether osteosarcopenia is a real entity, then it must be associated with clinical outcomes. And because at the beginning of my talk, I mentioned about falls and fractures, we looked at our own population in 2015 to check whether these patients, this is self-reported, so it has the limitations of that, whether patients found as osteosarcopenic, which are the black bars here, have higher numbers of falls in the last year or fractures, and that was the case compared to the other groups. So we found that these osteosarcopenic patients have more falls than the sarcopenic and more fractures than the osteoporotic osteopenic. But again, this is cross-sectional, this is self-reported, so it's very hard really to determine unless we have a study that is designed specifically for that. However, we think that if you have osteoporosis and you have sarcopenia, then you must have a higher risk of these events. To prove that, we did another study, and that is a more recent one that was with our cohort here in Melbourne, where we use a set of different models. First, because as I mentioned, it's difficult to define sarcopenia using just one definition, so we use the most common definitions of sarcopenia, And we included osteopenic and osteoporotic. So we tried to answer several questions. First, which definition of sarcopenia will be a better predictor of poor outcomes in the context of osteosarcopenia? Second, should we include the osteopenic patients within the osteosarcopenia definition? And this we consider very important because, as all of you know, osteopenic patients fracture. And fracture because we know that they have these bone structure issues, but at the same time because they are falling, and probably because they are at the same time sarcopenic. And what we found was quite interesting. We found that definitely there is a proportion of patients who have sarcopenia, but amongst these osteosarcopenic, we found that those with severe components. So if the patient has, independently whether they have osteopenia or osteoporosis, if they have a severe sarcopenia, we found that they have the strongest association with physical performance and with self-reported falls and fractures, especially when we use the ones that include the severe sarcopenia, like the second European. We identified those as a much higher risk of these events. However, again, I must highlight the limitations of cross-sectional analysis. These studies combine male and female, and they were done in patients with high risk of falls and fractures. This was done in participants at our falls and fractures prevention program. So that's some of the limitations. We don't have at this moment a longitudinal study designed specifically to test osteosarcopenia, and it's something that we are working on. And this is interesting because we don't know whether osteosarcopenia has also an impact or has associated with falls and fractures in men. This is an interesting study done by Marcus Siebel team in Sydney with the Concord osteoporosis or Concord study in men. This is about 1,500 men, and interestingly, they didn't find that osteosarcopenia was associated with higher falls and fractures. Some aspects to consider here is there's veterans, and most of them are, the majority actually, are good functionally. And the other important aspect to consider here is the definition that was used for sarcopenia. Nevertheless, there is a clear interest on defining whether osteosarcopenia has more significance in female or in male subjects, something that to look at the future. Other outcomes associated with osteosarcopenia. This is an interesting study done by our team, by our very bright research fellow, Ibrahim Bani Hassan, who look at the levels of hemoglobin in osteosarcopenic versus sarcopenic and osteoporotic. For many years, we have managed the concept that osteoporosis is associated with anemia, and sarcopenia is also associated with anemia. What was interesting from this study is when we found that osteosarcopenic and sarcopenic were associated with low hemoglobin, but the osteoporotic group was similar to the normal group and didn't show the same levels of anemia than the groups that were included sarcopenia and osteosarcopenia. And coming back to Julie Pascoe's Geelong osteoporosis study, she found something very interesting in 750 postmenopausal women. She found that what she defined as poor musculoskeletal health, which she was a little bit shy and not mentioning, not labeling them as osteosarcopenic, but clearly fulfilling the concept, the criteria for osteosarcopenia. She found that low lean mass exacerbated mortality risk to those with osteoporosis. So we can say, okay, the importance of identifying osteosarcopenic patients in practice is not only because we want to identify who is sarcopenic or who is osteoporotic, but also to identify somebody who, while having both conditions, is at high risk of poor outcomes. Now, we know how to diagnose osteoporosis. I don't have to mention that here in this audience. I already mentioned about some limitations in clinically diagnosing sarcopenia, or even imaging using appendicular lean mass. So we have been working a lot on trying to identify other alternatives on how to diagnose osteoporosis and sarcopenia together, and from the perspective of osteosarcopenia. And I think that we have already mentioned quite a few times about the importance of fat in this concept. So our team is working very hard to develop tools that quantify fat within the bone marrow using imaging, and also able to identify fat infiltration in the muscle. This is just some beautiful examples of the studies that again Dr. Bani Hassan and his team have done in terms of identifying this. Other groups have done fantastic reports on this area, similar area. People from McMaster, Andy Kwan from McMaster also has reported beautiful results quantifying bone marrow fat, which you can see here, and also quantifying muscle fat. Whether we can use this as a predictor of faults and fractures is something that will be interesting to look in the future. Ibrahim has also tried to demonstrate that probably we're focusing in some areas that are unusual regions of interest. Maybe we can demonstrate that measuring at the same time muscle, bone, lean mass, and fat mass, we can predict those poor outcomes. But so far, what we need in this field is something that accurately measures those two types of tissues, and you include fat within the equation, like here, like what they are doing here with this imaging. We probably get a better idea of what is going on. Some new techniques of measuring muscle mass, like the D3 creatine and other techniques that could correlate very well with the actual muscle mass, not as the limitations that we have when we only measure lean mass in DEXA. Probably those will be a good indicator when they will be combined with our fat calculations and our bone, the usual bone quality and bone mass calculations. Now let's move a little bit to the last part of my talk about the therapeutic interventions, and here is where, and I show this all the time because I think that, and somebody mentioned that before, that whoever identifies a drug that targets both muscle and bone will probably find the holy grail of the musculoskeletal field. And how can we really treat two birds with one stone is still a question to answer. There are some proposed pharmacological approaches. There are some non-pharmacological that, of course, have demonstrated some effectiveness. And when we talk about non-pharmacological interventions, well, we should talk about vitamin D, but definitely vitamin D is not a treatment for osteosarcopenia. It's not going to prevent this. And the way that if somebody has already osteoporosis, we are not going to correct that fracture risk as effectively as osteoporosis drugs, of course. But we know that vitamin D has an effect on a lot of these factors that are present in both in muscle and bone. Therefore, it has an anabolic effect on them. We summarized recently all the different non-pharmacological interventions that may have or had, when combined, they have an impact in muscle and bone. But I would like to move on to the pharmacological interventions because this is interesting. And starting with the myostatin, myostatin is clearly produced by the muscle, but it reaches the bone. And when it reaches the bone, it inhibits bone formation. This is clearly demonstrated when we inhibit when we inhibit myostatin or any of these activin signaling involved in muscle anabolism, we obtain this kind of big, nice muscle mass. However, when we treated, and this is a trial where we participated, treating older patients who have suffered a fall, really the results were very disappointing. Was a little bit of function, improvement on function, not that much on body composition. I couldn't find any solid evidence in humans of when treated with myostatin inhibition. There is some interesting studies in rats showing that when you inhibit myostatin, the bone mass increases, but just a few studies in humans, very small sample size, not very dramatic. An interesting area that is opening at this moment is the effect of denosumab. I'm sure everybody here is familiar with the Freedom study, where they found that there was a reduction in falls in the participants. and there must be something going on there, people thought, and the group from Serge Ferrari and his team in Switzerland did this study where it was actually small. They treated 18 postmenopausal women with denosumab and 20 with zoledronic acid. Interestingly, they found that those after 3 years of treatment, those on DMAB show an increase in appendicular lean mass and also an improvement in hand grip strength, and they didn't find any effect from zoledronic acid. Again, very small sample, but very interesting. And the most interesting part of this study was that they did also a basic sciences correlation, where they found that denosumab has an effect on muscle cells, especially regulating glucose metabolism. We also did that observation. We, in our clinic, we compared our patients, 51 of them treated with DMAB and 28 with zoledronic acid for 6 months. And this is the interesting part of this study, because in the study by Serge, it was about 3 years of treatment. Here in 6 months, we observed that DMAB displayed positive effects on balance, function, and fear of falling. We also found some positive effect of not only the DMAB, but also, interestingly, zoledronic acid. However, the most significant effect was from DMAB. Zoledronic acid also showed a very discrete effect on gait velocity, keeping in mind that this is a very small pilot study. So this is a summary of what we have so far in terms of pharmacological agents for osteosarcopenia. We have denosumab. I already mentioned about this. We all know about the effect on osteoporosis and the new understood effect of sarcopenia. Testosterone has not been a very dramatic effect in neither one, nor neither osteoporosis. In terms of anti-fracture efficacy, there is no, but we know that also in sarcopenia there is some improvement in terms of muscle, but is not effective in terms of preventing the actual outcomes, the falls and fractures. Growth hormone has also demonstrated or shown a not very limited effect on bone density, and just mentioned about the anti-myostatin antibody. So this is just to mention that we need something. We have to work on something that has an impact, that should have a beneficial impact on both muscle and bone, and that will be effective on preventing falls and fractures. In terms of recommending a clinical approach, we propose this one, which I will not go into all the details. I think that you will easily find it in the literature, and there are several proposed already, where we integrated sarcopenia within the osteoporosis algorithms. This is just to remind everyone who is involved in osteoporosis care, please don't forget to include sarcopenia assessment in your clinics, because we may be missing those subjects who are at much higher risk of poor outcomes. What are the future directions? And this is the last part of my talk. Well, remember fat, remember adipocytes, remember what they produce. They produce fatty acids. They are toxic fatty acids. We know that when we expose bone and muscle cells to these fatty acids, they die by apoptosis, they stop functioning. So why not to block the capacity of these cells to produce fatty acids? This is something that we did, and we recently published a couple of papers on that, where we found that oophorectomized mice, which show some of the typical features of osteosarcopenia, we were able to rescue them for that osteoporosis. And at the same time, and this is one I want to call the attention on, this area of the panel A of this figure, is we found that when blocking fatty acid synthase in these mice, we observe an increase in muscle mass. And this also brought us to the next step in this study, which was looking at the level of fat infiltration in muscle and looking at the effect of this fatty acid inhibition on muscle function. This is an area that will be an interesting area to explore in the future, because if we can, maybe we are targeting the wrong tissue, maybe we can go straight to that fat that infiltrates the bone marrow. Maybe we can prevent the differentiation of stem cells into fat, or maybe we can just alter the capacity of these fat cells to produce bad adipocytes. So the last slide is just to share with you my personal opinion about osteosarcopenia. I know that I'm biased, but long time ago, Bernard Isaacs, for those of you who are not in geriatrics, this is one of the fathers of geriatrics, and he proposed the geriatric giants: instability, immobility, incontinence, and intellectual impairment. We think that, and we know that osteosarcopenia could start early on in life and could be associated to multiple syndromes, but from the context of aging, we proposed very recently that osteosarcopenia could be a new geriatric syndrome, and why not another new geriatric giant. With this, I would like to clarify, this is not a new disease. This is a combination of two very well-known diseases which constitute a geriatric syndrome in the case of old people, or constitute a condition or a syndrome in younger population. With this, I would like to thank all the people around the world who collaborate with us, who have been all the time listening to our stories about osteosarcopenia. I would like to thank my team at the Australian Institute for Musculoskeletal Science, and also the people who pay the bill, the Melbourne Academic Centre for Health and the NHMRC in Australia for their funding for all these osteosarcopenia related projects. With this, I thank you for your attention. Thank you for taking the time to attend this webinar. I'm happy to answer your questions. Thank you very much for your attention.
Thank you very much, Professor Duque, for your outstanding presentation and covering this fascinating topic with preclinical and clinical data showing the interaction between the bone, muscle, and the adipose tissue. I'm sure your talk was greatly appreciated by our audience. And now I would like to move on to questions, as we have received many of them during the presentation. So maybe the first question I'm going to address to you is, are very high doses of vitamin D, like more than 500,000 international units per year, effective on osteosarcopenia?
This is a very interesting question, and the short answer is no. There have been quite a few studies, but one of the most significant ones was done by Kerry Sanders here in Melbourne, which was published a while ago, where postmenopausal women were treated with a very high dose, 500,000 a year. And very interestingly, those subjects experienced more folds and fractures. And the reason for that is it seems that very high dose of vitamin D have a deleterious effect on both on muscle and bone. For some reason, it induces an hypercatabolic state. So the recommendation is not to use this huge, very high dose of vitamin D to prevent folds and fractures, especially not in the context of osteosarcopenia.
Thanks. Another question. Can DXA help in the assessment of osteosarcopenia?
Which one, sorry?
How useful is DEXA for the diagnosis of osteosarcopenia?
Okay, good. I mentioned something about the use of DEXA to measure osteosarcopenia. We demonstrated that it could be useful, or may be useful, when you look at the specific areas where your region of interest, where you have at the same time fat, muscle, lean mass, and bone quantified by DEXA. This is something that we published, and I showed the study. Probably other more sophisticated approaches will be in the pipeline, and will have a potential to be a useful diagnostic tool. For instance, CT and PQCT, as long as we can quantify fat infiltration of those tissues.
Thank you. I have a question regarding to exercise. Somebody is asking whether you can discuss a bit more the role of exercise in addressing osteosarcoma, both the preventive and the therapeutic way in women who have developed osteosarcopenia.
Well, yeah, this is an interesting question because a lot of different studies have been performed, mostly focusing on separate tissues. So some studies have been performed testing the effect of exercise on muscle, and some studies have demonstrated an effect on bone. Very few of them have looked at the dual effect, at the dual impact of exercise on muscle and bone. what we know when you combine the evidence, and in this there are several groups that have been very active on this. Laura Gian Gregorio from Waterloo University in Canada, Rob Daly in Melbourne, and they have demonstrated that definitely we require to improve both muscle and bone. Again, rarely those studies have been combined, but when we combine the evidence on both of them, on all of them, we can deduce that strength exercise, progressive resistance exercise, and balance exercise will be are effective on these both tissues. There is also a group of studies from Wisconsin looking at jumping, control and supervised jumping on older person seem to have a good impact on both, on muscle and bone. And some of them, some are more controversial interventions, such as a whole body vibration, seem to be also have an impact on both, on muscle and bone. So despite the evidence is fragmented, when we combine them, the conclusion is almost the same. Is balance and resistant exercise and regularly perform, like a minimum of 30 minutes twice a week for 6 months, and protocols vary according to the researcher and the results, but this is more or less the general recommendations to keep bone and muscle mass healthy.
Thank you. I have another question related to Lamine, because somebody is asking if there are any data in the literature looking at the association between peripheral neuropathy and osteosarcopenia, as the lamina AC mutation are known to induce axonal neuropathies. Do you have any idea?
So I have not seen any studies, clinical studies, but definitely there is a biological explanation for that. And there is a biological logic, I would say, to explain that. Yes, the person who asked the question is correct. The peripheral neuropathy definitely affects denervation, affects muscle function, and recent very interesting studies have shown that denervation also affects, of course, bone biology. So it will be expected that in a peripheral neuropathy with a certain level of denervation will affect both tissues at the same time. But again, I have not seen it in a clinical setting, but it will be a very interesting study to perform.
Thank you. And maybe another question related also to osteosarcopenia. Again, is it more effective to prevent or to restore the loss?
Well, you're asking that question to a geriatrician. And I would say that what we see in our practice is the people who were never prevented. So I would prefer people to start preventing early on in their life, because what we don't want is to see the patients that we see at the orthogeriatrics program or at our nursing homes, where these people have suffered fractures, were sarcopenic for many years, they were never diagnosed, there was nothing an intervention, which is really unfortunate. So prevention is definitely important in medical practice at any age, at any time, to prevent the outcomes that we observe in our regular practice.
Thank you. So maybe a question related to that one. So if we want to prevent, at what age should we investigate patients? Should we start to investigate patients for osteosarcopenia?
Well, definitely, I will say that if the perimenopause is one of the critical time where both its tissues seem to be to decline. So I would say we could start those assessment at that time. Unfortunately, the actual clinical tools to measure muscle function and mass are not necessarily designed for younger population. Most of the performance measures that we used to diagnose sarcopenia were validated in older population. So we still need more accurate tools to diagnose sarcopenia in younger populations.
Yeah, thank you. Another question maybe also related to that. If you want to diagnose patient with osteosarcopenia, which biological marker or set of markers would you recommend?
This is a very interesting question. We did a study in 680 patients in Sydney, trying to identify the diagnostic yield of at least from the blood test that we order to diagnose secondary causes of osteosarcopenia combined. And we found with 4 or 5 important tests, definitely we recommended measuring vitamin D, we recommended measuring albumin, but very surprisingly, we found that the test with the highest diagnostic yield for osteosarcopenia was parathyroid hormone levels. And that was very interesting from what we found, and also testosterone in men. This is probably the battery of tests that we recommend. In terms of biomarkers, we recommend also, or we have tested other potential biomarkers. So this is one of our particular interests, which is circulating stem cells as a good biomarker, a robust biomarker. We have published some papers in that area, but we don't have at this moment a robust biomarker that will predict poor outcomes, because nobody has yet designed a longitudinal study focusing on poor outcomes and biomarkers for osteosarcopenia.
Thank you. Another question related to obesity. Do obese people have more marrow or intramuscular fat?
This is a very interesting question, because some people use the concept of osteosarcopenic obesity, and assuming that obese people are more prone to have osteosarcopenia. And the evidence at this moment is that the appearance of osteosarcopenia seems to be independent of BMI, and especially those levels of fat infiltration in muscle and bone marrow are not correlated with BMI. We observe, for instance, on the typical example, people with patients with anorexia nervosa, who lose all fat, they lose subcutaneous fat, visceral fat, they have high levels of bone marrow fat. So there is not a clear correlation that the mechanisms explaining that generation, local generation of marrow fat and intramuscular fat seem to be totally independent of the generation of the fat that we observe in obese patients.
I have a question related to preclinical data. Do lamin A mice respond to exercise? And there is another question: can fat infiltration be prevented in these mice?
Well, that's a very good set of questions. The first one, unfortunately, those lamin A knockout mice, especially the homozygous, die very quickly. They only survive about 6 weeks. The heterozygous, we exposed them to a strenuous exercise, and we published those results a while ago. They don't respond to exercise. They didn't correct their phenotype. It seems that lamin is required to the anabolic response of both muscle and bone. We didn't observe a change on the marrow fat and muscle fat infiltrations either on those mice exposed to exercise. So it seems that we need those normal levels of lamin A to respond to exercise. And just coming back to the previous question, we also we have been proposing that lamin A expression could be also used in the future. We have presented some data on that, and some other groups are working on that very actively to validate lamin A expression in stem cells as a potential biomarker for osteosarcopenia.
Thank you. Coming back to treatment or to future treatment, potential future treatment, do you think that there is a future for myostatin antibody to treat osteosarcopenia?
After participating in 2 major international clinical trials, I'm a skeptic, I must admit, in terms of the potential of this antibody. So I know some people are working on stronger antibodies, but I'm still, after looking at the results, we don't see this big muscle mass response. This muscle function is not changing that much, and definitely the bone mass didn't change.
Okay, thank you. I think now it's time to conclude. I'm sorry, but we don't have time to answer all your questions. But I really would like to thank you for your participation in this joint IOF-ESCEO webinar. We hope that you enjoyed this session. I just would like to mention that we will post a recording of this webinar on our website and that you will receive the link to the recording by email tomorrow. I don't know if Dr. Albou, would you like to conclude?
Thank you, Dominique. Thank you, Professor Diu, for this terrific webinar. Once more, it demonstrates that this topic is extremely important due to the participation that we had and the numerous questions. Thank you for your commitment. And again, I would like to emphasize the close collaboration between IOF and ESCEO. Thanking again our sister society ESCEO for this joint session. Have a very good day. Stay safe. Take care, and stay tuned for the next Bonecast issue. Bye-bye.
Goodbye to everybody. Have a nice day.